Well, thank you. Thank you for allowing me to give this presentation. It's something that I'm quite passionate about. I've talked before with Behavioral Echo regarding long COVID, which is one of the hats I wear at Queen's. But I was recruited by Dr. Shikuma and the Hawaii Center for AIDS to come and do research with them about 25 years ago. And so this remains to be a passion, the first epidemic within my lifetime. And I want to hopefully make Dr. Shikuma's dream come true of having an AIDS-free generation. And so with this, I'll start the talk off with preventing HIV and also STI transmission. You may have heard of the more controversial things such as doxy-prep, which I'm going to talk about today. And you may have already heard about the years of effort that we've had with HIV. So my learning objectives today is to provide you, if I'm not sure what I see, if I move is it blocking anyone's screen by chance? No. Oh, perfect. Okay. So the learning objective today is to review the epidemiology of HIV and then sexually transmitted infections in the United States, and then kind of talk about indications and contraindications when prescribing various forms of HIV PrEP, which is PRE, and then what we're going to get to more controversial is the doxy PEP, which is post-exposure prophylaxis, which will be just PEP. So these terminologies may not be familiar to you all, but just to note that there's a pre and there's a post, and that it's important to know the differences between the two. So why do we need a new approach to HIV? Many of you may not know that the epidemic is still ongoing. The HIV was first realized back in 1982, and since then we've had a pretty high epidemic with the initial. Many individuals were dying. It was leaded as the third leading cause of death among individuals from 20 to 40 in the 1980s into the 90s. It worldwide hit a infection rate of 44 million individuals at one time. And since the arrival of heart therapy or the extensive use of antiretroviral cocktails, we've seen a dramatic improvements in longevity and morbidity in our patients. And we've also seen reductions in transmission, which this talk doesn't really allude to, but you can imagine that people who are virologically suppressed in people who with HIV, that they're less apt to provide, have transmission to HIV negative individuals. This talk is mainly for people who are HIV negative, so people without any HIV, and we're trying to prevent them from actually getting HIV in the process. And so one's lifetime risk, if you're a man who have sex with men, and this is the terminology that the CDC have produced, it is not a, doesn't determine sexual preference. It's just that men having sex with men, you may be heterosexual, you may the sexual orientation may still be towards the opposite sex, but may have sex with the gender, men who have sex with men, and your risk would be higher. So in the lifetime risk in the people living in the United States, there's a 1 in 6 chance of actually developing HIV within the United States. And again, all of these are lifetime risk. Women who inject drugs, there's a lifetime risk in the United States of 1 in 23. Men who inject drugs is 1 to 36. Notice that the men who inject drugs is lower than the women, than 1 in 23. And it's primarily because of how women, they may, people who inject drugs, when I was in my residency, the whole concept of sex for drugs was a large issue, and so women may actually be at in the power structure, maybe may be made to perform more riskier sexual acts, may also have receptive, someone who's HIV positive in terms of receptive, non-receptive, in terms of whether or not penetration or non-penetration. You could see that for heterosexual women, that the risk is also, again, higher than heterosexual men, primarily that concept of being receptive, so seminal fluid being in the woman itself rather than insertive in terms of for the heterosexual males. And so again, the lifetime risk is still quite high, 1 in 6, and you could see going down the risk.
Dr. Chow, there's a question, if you can explain a little more what you mean about sexual histories when you say sexual histories.
Just in regards to, I guess perhaps could I get further clarification on that? So whoever asked that in terms of
Dr. Cohn, can you elaborate on your question?
Yes, thank you. I didn't mean to interrupt, but I thought it was something that's important to discuss, the use of sharing sexual histories before sexual activity and how that can be useful to prevent complications, unwanted results.
So we tend to have the 5 Ps, we try to teach a residents 5 Ps in terms of practice, prior STDs, partners, number of partners, pregnancies. I forgot what the 5th P was, but having a good sexual history is important to try to determine risk among who to actually prescribe PrEP to. And so we'll talk about that a little bit as we get along, but it's very important to get a good sexual history with your patients. And I think the newer generation of my residents, they are a lot more open, and they collect a sexual history much better than, say, when I was a resident. We tend to be less, a little bit more prudish and less, didn't collect a good sexual history as in the past. Did that answer your question, or?
Well, thank you. It was useful for sure, but I'm actually referring to teaching the public and patients and our family and friends about being responsible sexually and being able to talk about sexual histories and ask potential partners their sexual histories when, I mean, their sexual status, their sexual activity history, and when the last time they were tested for any STDs and what the results were, and sharing all those results before engaging in high-risk activities.
Yeah.
So I don't know if there are any programs in the medical field that address that, but certainly it's something I learned outside of medicine.
We in our residency program, we try to role play with our residents in doing that, and so great information in terms of that. And we will talk about, I don't know if I have it in my slides, but the landscape of sexual activities has also changed with the use of new technologies and phone. A lot of our clients are having anonymous sex, so they hook up with certain apps, and they may not know who their sexual partners are to ask those relevant questions. Oftentimes, I would say a good number of my patients are having anonymous sex, so they may have 3, 4, 5 sexual encounters maybe at a night, but not even know who the individual is. So those are the higher risk individuals that we want to start to really, the focus is with HIV PrEP as well as Doxy PEP in terms of protecting them against getting infection. And just you reminded me of technology also, in that we used to have in our clinic something called Tasha, and Tasha was a great device that we would give in the office while they were filling out the paperwork and getting checked in. They could have this device where they could talk about the number of sexual practices in their the number of partners in possible STDs or things of that nature on this tablet, and that also allowed that awkwardness of having clinicians talk to their patients. And so we would be already know a bit about their sexual practice orientation and things on this tablet. And then when going in, we could actually help with smooth that conversation to be more smooth. And so I'm just going to move to the lifetime risk of MSM. Again, the term is men who have sex with men. It is a CDC criteria. And you can see that African-American MSMs has a high rate of lifetime risk of HIV, 1 in 2, as you could see here. And primarily it's because geographically, which we'll see in the next slide, higher rates of HIV in areas where people of color reside in. So it is a big health disparity. You can see that Hispanic men who have sex with men, there's 1 in 4 lifetime risk. And then male white MSMs, 1 in 11 lifetime risk. And so when you look at overall geographically where HIV is currently still a big issue or a big pandemic, it isn't from the areas of California or the Northeast where I grew up in, but more of the Southern Belt, and access to care, cultural beliefs and such make sometimes access into accessing preventive services may be a little bit more difficult. And so you could see that for my home state of New York, you could see that the lifetime risk in someone living in New York is 1 in 69, whereas in Hawaii, the lifetime risk is 1 in 202. So, and then in the District of Columbia, it's very significant in that there's a lifetime risk of 1 in 13 lifetime risk of developing HIV. So clearly, if I haven't sold it to you, HIV continues to be a epidemic to this day, and that it isn't over. And so what can we do? Recently, we've had FDA approval of something called pre-exposure prophylaxis. As you could see here, before the HIV exposure, you could see that pre-PrEP or pre-exposure prophylaxis occurs before exposure to HIV, and that post-exposure or PEP is after the fact. And so we've always had PEP before, whereas we were developing antiretrovirals for HIV. We knew that exposure in terms of sexual abuse, assault, we did give patients PEP, but in this era of pre-exposure, we know that we could give medications before and preventing the long-term effects of HIV or HIV transmission. And so you could see here that what is PEP? It's highly effective HIV preventive measures, interventions. It is towards high-risk individuals to be taken daily, or by oral medication or by injection, and it's over 90% effective in reducing overall acquiring HIV. And so back in 2012, you could see that Truvada was the first medication that allowed for prevention of HIV transmission. And then subsequently, very similar to Truvada, that Descovy came on in 2019 as preventive also. You could see that the medications were basically identical in terms of imtransitidine, but the tenofovir portion was different. This is a different formulation from Truvada to Descovy, and it's primarily because Descovy is a prodrug of Truvada, and that this medication itself is a lot more safer for renal and bone. And so again, these two agents are very similar to one another. Just remember that this is a prodrug, meaning that you'll have less of the components inside your bloodstream, so less toxicity. And it may be the reason why it may not be so protective for some individuals versus other ones. And we're going to go into it in a subsequent slides. Primarily women, Descovy is not currently available for it. Aptitude is the first injection. It is an injection form that allows for prevention towards preventing HIV, and it's given every 2 months. And this allows an issue of compliance to be removed from the equation of HIV transmission. And so I'd like to show oftentimes the trials that were conducted, just so that you could see all the differences in their study populations. And these were the famous landmark studies for the IPREX, Partners PrEP, TDF2, and TIIDU. And you could see that each of these populations, when given PrEP, what are the reductions in this? All cases with tenofovir, the older form of Truvada. In these cases, you could see for IPREX, it was men who have sex with men, transgender women, in a variety of locations. In Partners PrEP, it was discordant couples, and so one couple being HIV negative and one HIV person being positive. In the TDF, it was heterosexual men and women in Botswana, and the TIIDU was individuals who are IV drug users. And so you could see that there is reduction in HIV transmission anywhere from 44 all the way to 67. And you probably were wondering, wow, that's somewhat a little low. I thought it was much better than that. And so in the next slide, you could see when they took into account compliance, whether or not you had any drop of or detection of tenofovir in your bloodstream, you had a higher rates of efficacy. So in the IPREX study, overall efficacy was 44, but if you had detected samples of tenofovir in your bloodstream, it went up to 92. And you can see that all of these, like the Partners PrEP, the TDF, and TIIDU, all were improved from the lower overall efficacy to higher efficacy with compliance. And so when you look at the trials, this graph really says it all. If you take more than 7 tablets per week, you have a very good protection against HIV transmission. However, when you start waning from your overall compliance, 4 to 6 tablets a week, 2 to 3, and less than 2, you could see that overall HIV protection wanes. And so if you're able to take it every day, you have over 90% overall protection from getting transmission of HIV. Some of you have heard of something called on-demand PrEP, and this is only for men who have sex with men. There's no data on Descovy yet, but what would happen is that if you have sex on, say, on Friday, you would try to take 2 tablets of the Truvada before on Thursday, have sexual act on Thursday night, and then take it on Friday and Saturday. We don't really like to do this, but we see that there are individuals who otherwise don't have, who aren't having regular sexual activities, but may just want to just take it on the times that they are engaging in sexual activities. But it's a lot different. It's not easy as taking 1 pill a day. Blood levels aren't that as high, but you could see that there is an option for people who don't like to take medications all the time. And so just a little bit more, it did show high efficacy. It did show a 86% reduction on the APA on-demand PrEP. So it is still an option. Again, we don't like to necessarily do that. We like to actually have daily usage of medication. So who is eligible? I think the question was who's at higher risk and who would benefit from PrEP itself. Again, it's PrEP. So people who have sex with men who have a HIV positive sexual partners, very similar to the partners PrEP study itself. People who have STIs are very at high risk. People who have high number of sexual partners. So any 2 sexual partners at any given time is considered high risk. A history of inconsistent or no condom use, and then commercial sex workers. These are our individuals here. And then people who are heterosexual men and women, that is again, people who are high risk would be HIV positive partners, again, STDs, again, the number of sexual partners, no condom use, and then commercial. And then in a high prevalent area is also in this realm. And then people who use IV drug use or needle sharing are definitely at risk and for developing HIV and would benefit from taking PrEP. So how do we give it? Well, it's different for both men and women. For men, we will talk about the for men who have sex with men. You could get both Descovy or Truvada or the injection. And in men, by 7 days, there will be adequate levels in the rectal and urethral tissues to prevent HIV transmission. For heterosexual women, it is only Truvada right now. There was a study with Aptitude that we're quite excited about, but I don't believe it's been thoroughly approved by the FDA. But Truvada right now is the only medication. But for women, they need to wait 21 days before engaging in sexual activity. That's when we know there's adequate drug levels in the cervical vaginal fluid. And some criticisms, I won't elate too much, is the Descovy criticism. Again, this is a pro-drug. There were not enough women who were included, and there were not enough drug users to actually say that that Descovy can be used in heterosexual women and also IV drug using users. And so again, notice that there's a difference between Truvada and Descovy. The differences between MSMs and transgender women in terms of women, heterosexual women, and that each of these are the types of medications that could be used. And so we used still HIV testing, third generation testing. So any of the large medical centers, both Kapilani and Queens, will use at least the third generation HIV testing. This is just a summary of basically of all the people who are given the medication itself. And then my colleague, Dr. Gankako, actually kind of spelled it out in terms of the benefits of each of these, in terms of mainly for the options for men who have sex with men, because they are able to take all 3 of these types of therapies. And I won't go into the nitty-gritty details. I think this is something that should be left with the clinician, with their patients. There is a big price difference. So for Truvada itself, the cost is about $25 per month. For Descovy, it could go into the realm of thousands of dollars, and also for IV, for cabotegravir, the injection and the administration of the injection is also has to come into play of how much it costs. This slide I just had to sneak in because I think
excuse me, Dr. Chow, do
Sure.
you know when Descovy is coming off patent?
Oh, I think in 2 years. I think in 2 years. I'm not clear on that, but it will
Okay.
be, I believe, in 2 years. And then
Thank you.
hopefully that will dramatically reduce the price. I
We
remember,
would expect.
so, yeah, we
Thank
would
you.
expect, yeah. I remember the day before with Truvada, it was like $1,400. And then right overnight after the patent had gone, and they started like a month or so afterwards, it started to go down and down and down. And now it's only $25 per month. Versus thousands of dollars. And it blows my mind that things could rapidly change from thousands of dollars to only less than 25 bucks. Don't get me started on that, on generics and such. But just to talk about U equals U, I did mention for people who are HIV positive, they are in our clinic, we want to normalize their overall um, uh, uh, activities, as we know that people who are HIV positive, who are undetectable, meaning if their viral load is reduced to undetectable levels, less than 200, that they are untransmittable, meaning that my clients in our HIV clinic will not be able to transmit HIV to anybody if they hit undetectable levels. And so again, this is a discussion that you would talk with your HIV positive patients, not from what I showed before, but in these cases, for our positive individuals, this is another tool in trying to reduce the whole HIV epidemic, in trying to get to a AIDS-free goal. And so this is a conversation I have with my clients all the time, in trying to get them to be compliant, and trying to get them to be undetectable. And I would say we do a very good job, because over 90% of our clients in our clinic are undetectable and they are untransmittable. So U equals U, very normalizing in the message we're giving to our patients. And
Dr.
so,
Chow, sorry to interrupt.
yeah.
There was a question in the chat, and I think you just answered it, but just to confirm, so the U equals U is 100%. So if you're undetectable, you're not transmitting it at all.
Correct. Yeah. And so every year or so, a good friend of mine, Paul Sachs, he actually has a commentary on the whole issue of PrEP, and in terms of U equals U. And so far, knock on wood, nothing has occurred in terms of anyone who's undetectable has not resulted in any transmission to a HIV negative individual. So very powerful in terms of getting all our patients who are HIV positive to their goal. And so this highlights our charge from the global challenges, as well as our goal of hitting the mission of 90% in 10 years, of trying to get everybody who is HIV positive to be on case managed, and then to actually have a HIV viral load of being undetectable. And so I think for our state in Hawaii, we're doing pretty well compared to other states. And so I'd like to stop off the HIV portion before I get into the doxyprep, the STD portion, by just giving a case study. It helps solidify one of the things that we've learned today. So a 24-year-old man who's referred from a STD clinic, he has 5 male sexual partners per month. He engages in oral and anal sex. Condom use is inconsistent. He has no chronic medical problems and no prior sexually transmitted infections. And physical exam is unremarkable. And then his recent HIV testing 1 month ago were both negative. And so I think from what you heard, this person would be an ideal candidate for HIV PrEP. He's a male. He's adult. He's does not have HIV infection. He's has had sexual partners in the past 6 months. He's not monogamous with any relationship, and then at least he's having sex without condoms, STD diagnosed maybe in the past 6 months, and ongoing relationship, or any of these, you may decide as a clinician that this may just be enough to warrant use of PrEP. Again, the risk of the medication versus the benefits of the medication should be weighed in all your clients. If this patient had renal disease, there are, differences that one could manage. Aptitude is now a medication that doesn't require renal dosing and might be something for your renal insufficient patient. So things to think about, things to talk with your patients and to try to get on board. But again, in the era of harm reduction, meeting patients where they are, I think this is a very strong message and a very good intervention in reducing one's lifetime risk in catching HIV. So I have to just give a shout out to the Department of Health. They have been doing a fantastic job keeping all the providers as well as the ASOs and the health centers all in, kind of abreast of the HIV situation. We have our annual Hawaii to Zero symposium every year. We just had our last one on September, where 3 of the surviving 5 cured HIV patients came to Hawaii, and we heard from the Department of Health that there still are about 50 new infections per year in Hawaii. Most of them, there are some people who are from mainland, who are positive, who just relocate. That's not our concern. Our concern are mainly the people who have developed new HIV infections within Hawaii. And so our goal is to try to get it to 0 and be the first state in the nation to have an AIDS-free generation. And so my good friend, Elizabeth Kiefer, she did a mathematical modeling for the state of Hawaii based on the Wales data that was published in the Lancet a while ago. She's found that basically if we could get 3,000 individuals, high-risk individuals, on PrEP, we basically will be able to shut down any risk of HIV transmission within the state. And so that's a big charge. Currently, at any given time, I think there's about 300 individuals on PrEP. So we still need to rack it up. If we could get a 10-fold increase in that number, I think we could really put a dent into reducing the number of HIV infections within Hawaii. This just shows the cost, where the Truvada, I think someone mentioned, is $25 per month. The Scovy, I think 1,000 to 2,000, and the Aptitude is 4,000. But again, Aptitude is given every 2 months, so it is almost the same as the Scovy. And then we normally, what is important is that they frequently follow up every 3 months to get HIV testing, also to get counseling on appropriate sexual safe sex practices, and then also to get tested for STDs every 3 months, and then also to look for kidney issues, which is the big factor for HIV PrEP. And so just to continue on the case, there are additional interventions, you could provide our sexually active patient with multiple sex partners with inconsistent condom use. Could we reduce his risk for getting STDs? And that's a big question, and the case for doxy PrEP. And this tends to be a little bit more controversial. It's not universally accepted yet. There have been only a couple of trials, not as many as that in HIV PrEP. But note that we're moving away from pre-exposure to post-exposure. So everything from doxy PrEP will be after the fact. So after the sexual event, and that is what the designation is. Okay, so globally, we see that the epidemic among men who have sex with men, the rates of gonorrhea has been increased. In terms of men and women, otherwise, the levels continue to be lower. Chlamydia, there also been higher rates, and you could see that that's although these look like they're lower, they are rising among the heterosexual females and then also men. And then you could see in syphilis, you could see the rising counts. And then I do know in pediatrics at Capilani that there's been an alarming trend of syphilis and syphilis for newborn syphilis risk. And so you could see that there's been an increase in overall numbers. In terms of testing, I think I have to tell you a story about our own clinic. We were only doing urine screening for longest time until the Department of Health offered to do all site testing for us, meaning that oral testing and also rectal testing. And we are very similar to some of the national data. Had we only done urine testing, we would have missed 77% of all the chlamydia cases and also 95% of all gonorrhea cases. This is data from our own clinic where you could see we were testing at a regular initiation 3 months, 6 months, 9 and 12. And you could see most of all our gonorrhea cases were all oral gonorrhea, and there were rectal gonorrhea cases, but there were only in a handful of cases where we found it in the urine. So by far, the majority of gonorrhea in our clinic was either from oral or rectal sites. And it is important to know that if you don't test, you don't know. And so it is important to do all site testing. And that if you ask your patient where they, this comes into the having good dialogue with your patients and talking about sex with your patients is important, where if they tell you they're only performing oral sex or anal sex, that's all the site you need to do. So it's site specific. So if they don't say they're not having urethral sex, you don't have to do that site testing for that site. So doxycycline for the case of proposing an intervention was quite promising. Early investigation showed doxyprep led to a 2/3 reduction in syphilis and chlamydia, and it was still questionable whether or not it was effective for gonorrhea. And just to note that as bicillin becomes a bigger issue in terms of supply, the reduction in syphilis is also very important. We can't get bicillin for our patients for syphilis. We've been advised by the Department of Health to primarily give the 28 days of the doxycycline. And so there's a mechanism of protection for all 3 of these infections. And so this led to individuals proposing whether or not doxyprep would be something to be provided to patients. These were people with HIV or without HIV, and they were randomized in a 2-to-1 randomization of either doxypep or no prep at all, and then following them with through time. Again, the inclusion criteria with male sex at birth, living with HIV or on PrEP. They had greater than 1 STD in the past 12 months, not similar to our case presentation. But as you can see, they were very stringent in terms of having at least 1 STD, so the highest of the highest risk patients, and then having condomless sex with 1 or more partners in the past 12 months. And then they just had these clinics in both San Francisco and Seattle, STD clinics.
Dr.
And
Chow, we
oh,
have a couple questions in the
sure.
chat. Back to the testing, can you speak to a little bit more of what STIs are detectable under which types of testing?
Oh, I'm sorry. So there is basically for us, we do the PCR, the NAT test, that NAT's testing for both the oral, rectal, and urethral or urine that we do. So we will commonly in our clinic will swab the back of the throat with a test kit, and I'll provide information about that. That gets sent off to the Department of Health, and now I heard that DLS is now on board of doing that. We provide a Q-tip for our patients. They go discreetly into the bathroom. They swab the rectal area, and then they put it into the tube for the NAT testing itself, and then finally giving a urine sample if they engage in urethral sex into a container, and that also gets sent off, all for NAT testing. And then these are not cultures. They're PCR type of technology where they'll look for bits and pieces of the syphilis or gonorrhea in the test itself. So those were for gonorrhea, chlamydia, and for syphilis, it is a blood test. We're looking primarily for RPR or VDRL.
Thank you. And then to the next slide, what do you do with individuals who cannot tolerate doxycycline?
Oh, okay. So there isn't anything yet currently that is not doxy. So I think we're trying to get kind of the acceptance of something of this nature before considering other agents. And so I know people will often say, oh, what about using other types of antibiotics? But right now, it's still very new. This whole concept is very new. We don't want to develop resistance, right, to these antibiotics, and so that is so I think someone, of developing resistance. But I have to say the resistance question we're going to get to a little bit in the future in a couple slides. Similar discussions were also said about the HIV PrEP. Which was, for many years before, and we have not seen the resistance pattern to develop against tenofovir or emtricitabine within the context of HIV PrEP. So that hasn't materialized, thankfully, and we are fully on board with HIV PrEP. Whether or not this will be the same for doxy-PEP will need to be, seen as larger and more studies are shown, and hopefully there won't be any resistance pattern. But there isn't so far. We're not encouraging any other interventions with any other antibiotic. We're just using specifically doxycycline for now.
Thank you.
And so the endpoints were that of incident STI for the study, and it had a 90% power to detect decreases in quarterly STI prevalence, and it was stopped early in May 13th, 2021. And these slides are from the doxy-PEP individuals. I know Dr. Julie Dosrowski well, and she provided me these slides. And it was stopped early because the endpoints were seen in favor of doxy-PEP with the trial. I won't go too much into the baseline characteristics. Know that there were individuals living with HIV and people without HIV on PrEP itself. You could see that it had a it was primarily white, but there were representations among Black, Asians, and other races. Mainly, they're all biologically male at birth, but there were transgender women. You could see that the rates of gonorrhea were very high, chlamydia and syphilis in these cases. So high risk populations, and you could see number of sexual partners were 9 in the past 3 months. So you could see high number of sexual partners, and then high rates of possible use of other substances in both groups. And you could see here that the primary endpoints in terms of STI, where if you were to stack them percentage-wise, you could see the doxycycline PEP versus standard of care. There's in the HIV negative group was dramatically reduced, and in the people living with HIV, dramatic also equally seen on both sides. And so overall reduction in STI was relative reduction of 0.35. So and all were highly significant. In terms of diagnosis, you could see that again, there's symptoms wise, there's reduction. In terms of individual gonorrhea, chlamydia, and syphilis, all of them showed dramatic improvements. And compared to the earlier study with Ibergay and the other experimental studies, you could see that in this case, in gonorrhea, there were a difference in this did show that there were also protection against gonorrhea. So this just shows the p-values and the rates of reduction in each of the groups. And so overall, you can see that in terms of rates, there's about a 66% relative risk reduction in doxyprep and in different subgroups that you could see. So Ibergay, which was kind of started us all off, was about 47% relative reduction, but all of these other trials have all shown about a 66% reduction, relative risk reduction in our populations. And so is it safe? And it's with adherence, again, people have to use this within 24 hours of having the sexual contact. So again, it's after the fact of the sexual event. So within 24 hours, they have to take 2 of the tablets of the doxycycline. And so I may have not made it clear, but it's doxycycline taken only once, and it's after the sexual event, 2 tablets within 24 hours. Some people always ask me, what if you had 2 or 3 sexual encounters in that day? It doesn't matter. It's only 2 tablets in that single day. If you have sex in the next day, it would be, again, 2 tablets on the subsequent day and nothing more. You don't have to continue it for a week. You don't have to do it. Is only after the event. So this slide just shows the rates of resistant pattern that have been formed both in the tetracycline, and you can see that the rates in doxyprep and standard of care are quite comparable on baseline and standard of care. So there was no obvious resistance development, but again, these trials are limited in number of years, and we haven't seen the full pattern, although I do hope that it will not show any particular pattern, and that this is another intervention in getting people to not only an AIDS-free generation, but hopefully a STI-free generation. So
Sorry, Dr. Chow, we have a comment and a question.
Sure.
That doxy-resistant gonorrhea that you spoke about seems like a serious condition.
Mhm.
That was by a comment by Dr. Cohn. And then we have a question. Is that for 200 milligram tablets or 100 milligram tablets?
Perfect. Yeah. And so I'm not aware of doxy 200 milligram tablets, but it is the 100 milligram tablets. So it's 2 of those to make 200 milligrams and just taken once. And there's differences in, I think there's 2 forms of doxycycline. Either one of them can be given. I know that there was a question whether or not there's long-acting doxycycline, but either forms that you could get in pharmacy is currently available and can be given to your patients for doxypep. So it is important that this is only a intervention, and that you still need to counsel patients. People who are having a lot of high number of sexual partners, I do talk to them about condom use, and then also kind of talk to them also about potential of sex addiction, and then maybe trying to see how they could even do small things to try to reduce the overall risk of catching STDs and HIV. So those are kind of private conversations that you have with your clients, and it is important to do regular testing. So this isn't enough that you provide the prescription for your patients, but it is very important to do regular STI testing on a regular basis and at all sites. Again, oral, rectal, and anal, and then urethral urine testing, because just if you don't test for it, you won't know. Okay. It's an effective strategic intervention for your high risk patients. And so uh, going back to our case presentation, the client, although had a high number of sexual encounters, may not be a candidate for PEP because he has not met the criteria for what was seen in the trial, that of having a STI within the past year. So our client, who you recall, was a male who had a fair number of sexual partners. He had no chronic medical issues. He had no prior STDs. And so he might not be necessarily fit the mold of the patient, but clearly he's at high risk. And so we do, we practice not based on studies, but on your relationship with your patients. And so with that, I just want to summarize that the HIV PrEP and the STI PEP have been proven to be effective, no doubt about it. I think both are very highly effective. How to use it in certain situations is a concern, and we do have to find a model of how to get to zero. Medical literacy is important. So far, the word hasn't gotten out to our high risk person that we could prevent HIV transmission. I think there needs to be some acceptance and reduction in stigma. Patients who take HIV PrEP are often viewed as being promiscuous and not being a good person or citizen. That shouldn't be that stigma should go away. And that regular testing is important in trying to control the infection, and also enforcing kind of behavioral changes. Condom use is by far the most important. And then human behavior is sometimes hard to control. So that's why a harm reduction model is highly encouraged. And then I'm very optimistic as we get more and more of these interventions, as more injectables becoming more available, that we can get to an AIDS-free generation. And so hopefully with your help, we can get to that goal. And that hopefully at a Hawaii Hawaii to Zero, we can finally say that Hawaii would be the first in the nation to have 0 new cases of HIV. And so I'd like to acknowledge many of the individuals at the Hawaii AIDS Education Training Center. I know Dr. Louis is now taking on that. Shout out to the Department of Health in their great efforts in controlling the HIV epidemic as well as STI. And then with the Hawaii Health and Harm Reduction Center under direction of Heather and Nandi, they've been awesome in terms of supporting clients and getting their needs. And then just talk a shout out to Julie Dabrowski, who was on the DoxyPrep, spelled it wrong, DoxyPrep study team, as they were instrumental in getting this to fruition. So with that, I'll stop and answer any of the questions you may have regarding HIV PrEP and DoxyPrep.
Thank you, Dr. Chow. We do have one question in the chat. What about other infections such as UTIs? Does that increase HIV as well?
Not to my knowledge, not UTI, but any ongoing infections may allow for a portal for HIV transmission. So typically we think of genital lesions, rectal lesions. So if there are any lesions such as syphilis, we do know that syphilis is a conduit for HIV infection. So, on the shaft of the penis, if there is a lesion, that it could provide higher rates of transmission in both the person who's the receiving as well as the insertive person.
Thank you. Any other questions for Dr. Chow? We're coming to right about 1 o'clock. If there's no other questions, thank you so much again, Dr. Chow, for coming and sharing with us.
Yeah. Thank you again, and I hope to work with you all in trying to get to our goals. It's wonderful that you all are focused on prevention, and so I'm always available. If you have any questions, just reach out and just contact me.
Yeah, many thank yous and mahalos coming in the chat. Dr. Chow's, all of this information is available on our iEcho website. I've downloaded his PDF of his presentation there. Dr. Chow, please check the chat. Lots of thank yous. Next
Thank
week, we have Dr. Westfall joining us, and he'll speak on dementia and Alzheimer's. Happy to have Dr. Westfall back as well. And until then, have a great week, everyone. See you next Tuesday. Oh, we do have a question from Dr. Weir. If you are able to stay on just a couple more minutes, Dr. Chow.
Sure. Yep.
Do you test for or encourage Hep B immunization?
Yes. So we in our clinic, we don't test for development of immunity. We only do that for HIV positive patients, but in the general population, we strongly encourage people to get vaccinated. I think your question, is it correct? Your question is whether or not the general population. So general population, I think you were just promoting vaccinations, but for our HIV patients, we always test for hepatitis B and C. In our PrEP patients, we also do Hep B and C too. Hopefully I answered your question.
Thank you. Dr. Weirs, did that answer your question? And anyone else who wants to throw some questions in the chat or just unmute yourself, please feel free. Other than that, I think that's it. See you guys next week.
Thank you, guys. Thanks for participation. Thanks. Bye-bye.
Bye.